It's an honor to speak to you guys. And I know some of you guys have heard some of this before, but certainly sleep and autism is, sleep is important in all children in my eyes, but certainly more so in this subset of children that struggle a little bit more with sleep. So let's go to the next slide. So just an overview. We're going to talk about sleep and the autistic spectrum disorder, the 4 A's of autism and sleep. And that's really an approach you can use to evaluating and treating these patients on your own, tips for success, and some treatment options. Next slide. So it's a common comorbidity, as I alluded to earlier. It's estimated that 50 to 80% of children with autistic spectrum disorder have sleep difficulties. Challenging daytime behaviors are frequently a result of poor sleep. So just putting this in perspective, in the adult without autism, we expect that 25% of adults experience autism at some point in their life. And here we have a group of children where up to 80% of them are experiencing it before the end of childhood. So clearly this is a big deal. And what I always explain to moms and patients is when you sleep deprive an adult male, stereotypically they get sleepy. Their Epworth sleepiness score rises. They can't stay awake. When you sleep deprive an adult female, stereotypically, they don't complain as much about sleepiness, but much more about fatigue and exhaustion. And then when you sleep deprive kids, they can't focus or concentrate, which is why, the treatment, or one of the treatments for hyperactive kids that can't focus, is the substitute for sleep, which is speed. If all of us had to spend the night up one night and then work the next day, the drug of choice would be taking some sort of a stimulant to replace the sleep that you missed. Next slide. So what is insomnia? It's either trouble falling asleep, staying asleep, or else early morning awakenings. What's important to realize is it's really just the perception of this. So whether or not the patient is truly having trouble or not, it's our job to treat it as insomnia if they think that it's a problem, because this is so much mind, emotion, and kind of brain physiology all tying in together. I always refer to the I can't fall asleep as initiation insomnia. I can't stay asleep as sleep maintenance insomnia. And the initiation insomnia tends to be the bigger issue with kind of a kid with just kind of ASD sorts of issues, whereas the I can't stay asleep becomes more of an issue when there's a organic disorder of sleep, something like sleep apnea or periodic limb movement disorder being the two most common things we would see. Next slide. So the first of those 4 A's is ask. So I think this is the one thing in both the pediatric and adult world that we do least. I think that when we ask and we get answers, I think we do a really good job at responding and acting on them. But I think listening to the tail end of the case you guys presented, it's really easy to think why you might forget to ask about sleep when you have all these other, troublesome daytime behaviors that are challenging you guys otherwise. So it's really easy for me to preach this when I'm looking through very small blinders. So what do you ask about? Do they have a tough time putting them down to bed when they sleep? Do they snore? Any issues falling asleep? Any issues staying asleep? When they do wake up at night, what do they do? If they don't fall asleep in the beginning of the night, what's the bedtime routine? In sleep, even in children without ASD, it's routine, 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 adults as well. But as you can imagine, in this subset, it's even more so. And then always ask the mom. I mean, the mom knows when there's an issue. I shouldn't say they know when there's an issue, but if mom thinks there's an issue we need to address. Some people use these child sleep habits questionnaires. We don't in our office. And some specific questions, what's normal for falling asleep? Falling asleep in 20 minutes or so is about normal. Do they fall asleep in their own bed by themselves, or do they have to have someone laying with them? Do you feel like your child looks rested in the morning? That's really the, getting enough sleep. Do they look rested? Do they look tired throughout the day? And if they don't, how much do they wake up at night? If they do wake up, do they come join you in bed? Do they go out and start playing in the living room? Do they turn on a TV? What goes on when they wake up at night? So really just opening up and trying to get a big picture of what it might be like to spend a night in their house. Next slide. The second A is assess. And this is where we can start to collect some data. One of them that's super helpful is a sleep log. Again, I'm super aware of how this is just one more things to people to do. We use a simple kind of morning questionnaire sort of log where the mom will put an arrow down where she thinks the patient might have gotten into bed, arrow up where they got out of bed, and then you shade in where you think they slept. And then usually we'll have comments to the right. The main comment I want to see is, did the patient take any sleep aids that night? If so, what dose and at what time? And we're really trying to just figure out cause and effect. And most of the time, what we're able to demonstrate with a couple of weeks of sleep diary is that the medications make a lot less impact than does the family's behaviors. So they start to see that the issue with the kid not being able to fall asleep on Sunday night has more to do with them sleeping in till 11 o'clock on Saturday and Sunday than it does to the fact that they took their sleep medicine and it just didn't work. The environment, you want to give a picture of what it's like in the house. Are they in their own bed and bedroom? Is it dark? Is it quiet? Do they not have any screens in the bedroom? If the kid's old enough to have a cell phone, the cell phone shouldn't be in the bedroom. And then moving on to the associations, what does the child need as far as a routine to go to bed? We all know in younger children, transitional items are helpful and certainly more helpful than requiring, to be rocked or cuddled by mom in bed or dad, but having a blankie or a stuffed animal or something along those lines. And also along the associations, any particular routines. This is a group that I must admit I tolerate more screens than I would otherwise in a kid without autistic spectrum, just because in some of these kids, the monotonous rewatching of a clip or something that they've watched 10,000 times is what it takes to settle them down. So this is the point where I'm a little bit more open than I would be in another kid. No screens, no matter what, at least an hour before bed, but more listening to mom and seeing what's used to soothe the child. A lot of the issues we have in insomnia in children without autistic spectrum is their inability to self-soothe, right? Which is a huge thing in society now. We see it all the time. Kids come into the office and the first thing the parents do is give them their cell phone or give them something to keep them occupied, as opposed to training a kid to be able to sit there and be bored a little bit, but behave themselves and be quiet and answer questions when they're asked. And I think a lot of this self-soothing behavior is how we train them at night. Similarly, and that's why, when you're training a healthy little child, you don't put the child in their crib when they're sleeping, but you like them to be drowsy but awake so that they learn how to soothe themselves and go to sleep. And the same thing goes with every nighttime wakening. We don't want mom and dad to run in there and lift them up and snuggle them and say everything's going to be okay, but instead kind of use this graduated extinction approach where you kind of open up the door, you make sure they're okay, you put their hand on them, tell them they're okay, and then kind of leave the room. Again, reinforcing or teaching a child that they're safe, they're not being ignored, but it's important that they learn to soothe themselves. And then we got to figure out what other medical comorbidities can be contributing to this. Anxiety being far and away the biggest one. And all of us adults know that anxiety affects our sleep. Medications they might be taking, timing of the medications, particularly stimulants, make sure that they're not taking a controlled release stimulant at 11:30 in the morning, and any other things. Gastroesophageal reflux disease is a common comorbid condition in infantile sleep apnea. And unlike adults, where you treat the sleep apnea and the reflux gets better, in young children, you can treat the reflux and actually the sleep apnea gets better. Next slide. So next A is addressing this. Where do we intervene and what do we do? So we got this data. We realize things are kind of not optimal. What should we do? So there are worksheets, and you guys all have access to these worksheets through Project Echo. But bedtime routines, working the family through a healthy routine without screens and encouraging them to follow a regular routine. As I mentioned earlier, it's helpful for all kids, particularly these children. No screens before bed. Um, Aside from the blue wave lights, even if they put on blue wave light filtering glasses, put on the dim screen or the night screen, the data clearly shows that having a screen in bed promotes wakefulness. A lot of it has to do with the pacing of it. um, you're just being encouraged to click and keep going rather than something like reading a paper book where you generally it's self-paced, you read slower and slower and go to sleep. And similarly, that sort of happens when mom and dad are reading as well. So whether it's parental reading or the patient reading themselves, kind of my compromise in kids that might not have the cognitive abilities to read, but certainly enjoy storytelling. I think audiobooks are fine, podcasts are fine, as long as it's not a process where they're having to interact with a phone or a device to get this going. Um, Parental patterns, it's a lot of it is explaining to the parents that this sleep issue is important and this will affect their daytime function. And a lot of it's being quite frank with their bedtime routines because good sleepers do all sorts of things wrong and they still sleep. And a good sleeper can have a kid that's a bad sleeper, which is frequently the case. And so they're doing everything they know and everything that's worked for them for sleep, not realizing that they're making it more difficult for the young one in the house. Address any underlying medical issues. In our world, the biggest issue is making sure they have psychiatric follow-up as well. Fortunately, in your patient population, that's almost always the case where we have a lot of support built in, and it's much easier than me seeing a random kid referred off the street. And then some of these kids just don't sleep as much as other people. And this is, when you look at how much sleep a child needs, it obviously changes over through their life cycle. But when you get to adults, the bell curve's pretty steep, right around 7 hours and 20 minutes. Very few people get by with less than 6 hours and 45 minutes and function normally when you test them in the morning. And very few people truly need more than 8 hours. When you look at short sleepers, there's a disproportionate amount of short sleepers that fit in the ASD bucket than is compared to the non-ASD bucket. So some of these kids really do only sleep 6 or 7 hours a night. They look rested in the morning, and the parents are just flummoxed by it. Now, is this something I accept as gospel from the first visit? No. I go through the whole workup and I try to extend their sleep period, try to see if there's something waking them up. But sometimes you just got to step back and say, not everyone fits the textbook. Next slide. Excuse me. And then we kind of adjust. Rarely do we fix things at the first visit at a sleep meeting. And what I think the strength of our practice is, whether it's adults or kids, is we pester patients and see them back pretty incessantly. And that's really what you need to do. You need to review sleep diaries, see what changes were made, quickly eliminate the things that the family was relying on that didn't make any difference, and start refocusing on the things that you can see objectively making a difference. Track the improvement, encourage people. Even when they make changes in behavior, you don't necessarily see the changes in sleep the next night. So providing support. When you institute behavioral therapy, I always warn patients, you're probably going to feel worse before you feel better. And that's because I'm taking away your compensatory mechanisms, whether it's sleeping in on the weekends, napping after school. All these things are going to make you feel worse. But because you'll be more tired going to bed moving forward, it should improve things. So just kind of giving encouragement and warning them that it's not going to be easy, And I always tell them, listen, if I had a magic bullet or a magic pill, I would prescribe it to anyone. But the fact of the matter is medications don't work as well as behavioral changes. And you also got to let them know that there's hope. These parents frequently, when I see them, they've been kept awake for months or years on end, and they think they're going to have to live like this forever. And just providing them some reassurance that there is light at the end of the tunnel, and we do fix these things. Next. So here's a an algorithm for how you can work up a patient with insomnia. So the patient comes in, you look for they have insomnia, you look for potential medical contributors to it. Gastroesophageal reflux disease, anxiety. A true medical issue that could be causing issues. And then you assess the family and see if they have the skills to make behavioral changes. That's not always the case. You have an overwhelmed single mom with 3 or 4 kids. Sometimes it's not the best thing to throw out them and drop more responsibility on their lap at visit one when they're overwhelmed to begin with. And sometimes then I'll look at some of the more organic sleep things like, their potential obstructive sleep apnea or limb movement disorder or things like that, and changing very small behaviors before you put them on a rigid schedule. And then you can kind of see these patients back and see how they're doing. If you find there's from the get-go, if a kid is snoring or he's twitching all night or he never stays asleep or after a good night's sleep he never looks rested, or you might refer somebody to sleep medicine right off the bat, whereas somebody with what appears like some low-hanging fruit, as I call it, in terms of their sleep hygiene or their whole routine and scheduling, if you have a family that's willing, we hold off on a sleep study. These are not pleasant children to do sleep studies on. And if we could fix these issues without a sleep study, the better. In general, we don't do sleep studies to see why someone can't fall asleep. It generally more addresses why are they not staying asleep. Next slide. So if the insomnia is not resolved at that point, you can send and ask for help. There's kind of a couple of ways to go about it. If it's just falling asleep issues and the kid is older, you can use cognitive behavioral therapy for insomnia. We have Kyle Davis, who's a PhD in town, who is like unbelievable at working with patients and families for insomnia. Or else you can continue to manage that on your own, or else refer to an office like mine or St. Al's or St. Luke's, where you have people that may or may not be interested in managing pediatric insomnia. I can tell you at our practice, it gets dealt with just because we feel like we have to. We take care of everything and want to be one-stop shopping. You definitely, when you get into some of the bigger groups, there's people that one, aren't trained to do this, and they're mostly taking care of adults, or they're taking care of insomnia, but they haven't seen kids with autism and insomnia. So the expectations have to be realistic. And unfortunately, as overwhelmed as all the systems are, it's tough for me to blame fault when I kind of look at someone that was seen at one of the hospitals and then winds up at our office. It's rarely that someone didn't do their job. It's just they didn't wind up in the lap of the right provider to begin with, if that makes any sense. Next slide. So where do we start? Bedtime routine. They talk about this bedtime pass. You want to have a similar routine every night with no screens an hour before bed, warm bath, no food right before bed, read ideally in a perfect world, listen to music, something along those lines. You want to limit the excuses at night. I need one more hug. I need one more drink. I need one more trip to the bathroom. That's called limit setting sleep onset disorder. And the way we deal with that is we give the kid a pass and we say, you get one of these a week. So if you need a special trip, you can use one of these a week, and they learn to extinguish their behavior. Light timer, I have no problem with the light staying on in the bedroom all night. If a kid wants a night light, no harm done, especially if it's not an LED bulb. You do have to worry a little bit with LED bulbs. Is it one that's putting out blue wave light? And you want a quiet, calm environment, which I think a lot of us take for granted. But in some of these lower socioeconomic situations, bedtime is a hectic time in the house. People are leaving for night shifts, coming home from day shifts, and it's just chaos. Next. So melatonin in the uh, population of patients with ASD has been shown to be more helpful than it is in the general population, and data has shown that you can go up to higher doses. I rarely go above 10 milligrams in anybody. There is some data that people have gone as high as 15 or 20 milligrams in the autistic children. It's not generally something I do. If they're not responding to 10 milligrams, um, I'll either stop the medication and try something else or continue the medication and add something else. Other medications we commonly use in kids, clonidine would probably be number one, two, and three on the list. And of note, it's always interesting to me that clonidine is indicated for um, uh, ADHD as well. And the reason being is that it improves their sleep and they behave better the next day. So it kind of reinforces what we've learned since then. And then if they're snoring, you can send them to an ENT, you can send them to a sleep specialist. It shouldn't change the workup. I will tell you that there are plenty of ENTs that'll do an adenotonsillectomy without doing a sleep study first. So if that's your modus, that's probably the best place to send them. You send them to a sleep specialist, and most of us are purists and will insist on some sort of a sleep study before we take out tonsils and adenoids, for example. When you're treating obstructive sleep apnea in children, adenotonsillectomy is effective 55 to 70% of the time. When you combine it with rapid maxillary expansion or orthodontic intervention, it's about 90% effective. Um, Next slide. Change, and it never hurts to change the setting if you can and give the kid a new start, you know? So I always, if it's a family, I recognize they have these resources. Go to Target, pick out a nightlight, pick out special sheets. If you don't have a weighted blanket, it's time to consider a weighted blanket, although I probably should have brought that up earlier in the whole treatment process, because with the sensory issues, it does tend to be something that subjectively improves things. And once you change the environment, that's when you make the changes to the bedtime routine, so that psychologically and emotionally, the child notices that this is different than what they've tried in the past. Sunlight and blue wave light matters. So not only eliminating it in the evening, but exposing the child to sunlight in the morning is super helpful in terms of training their circadian rhythm and keeping them on a regular cycle. It's tough to do this time of year just because it's dark in the morning when they get up. And then, obviously, meal times, we talked a little bit about that. Kids getting exercise is helpful. You don't want them to exercise immediately before bedtime, but sometime during the day. Next slide. And it's all about routine. I mean, you guys know this. I heard you guys referring to this earlier in the case presentation, but this is all children, specifically children in your patient population. These visual schedules are not something I generally use on a day-to-day basis, but these are a project, Echo sort of resource, and I think it's great because I think my style of writing down a routine or pointing to a written routine is great for the parent, but I think what I do frequently doesn't have the kid engaged enough in their routine, because in a perfect world, as the kid gets older, they follow the routine on their own. And most of our good pediatric sleepers do that as they get older. And I'm not as big about the consistent bedtime. It's all about the consistent wake time and limiting naps. If they get up at the same time every day and they don't let themselves nap, their bedtime should fall, depending upon their age, X amount of hours before their wake time. So I say, well, I would expect you to get sleepy at X time because it's 10 hours before your wake time and you're 10 years old. So what I would like you to do, if that's 9 o'clock, no screens after 8 o'clock, and let's start our routine at 8 o'clock at night. So wake time more than bedtime. I say that, but I must be quite frank. I have a 12-year-old daughter who is a night owl. And if we weren't on her about her bedtime every night, she'd stay up till 12:30 and she'd be a zombie for school in the morning. So everyone's a little bit different, but the wake time is everything. Make sure the time is right. You don't want to put the kid to bed earlier than they need to be. That's a common thing that parents do with kids with insomnia is they're not getting enough sleep. So they put them to bed earlier, and you really just exacerbate the problem. The child starts to associate laying in bed with being awake. So you want the kid to be as tired as possible when they do get to bed. And you got to recognize and address any sort of circadian rhythm delays that you might see, particularly as the child is entering adolescence and maybe not quite tired at 9 or 10 anymore. And if you want to get them tired at 9 or 10, you've got to do some tricks, whether it be, um, um, you know, melatonin in the evening, possibly, or else, even more importantly, blue wave light therapy immediately upon waking in the morning. Next up, pharmacologically, it's always really important to figure out where the family is coming from. Some parents are not going to be happy without a prescription. Other parents won't be happy if you discuss drugs, right? So I'm really not a big prescriber for insomnia in kids or adults. I use them as crutches. And I always tell a patient, you don't need to take this every day. Just on your sleep diary, documents which nights you're taking it and which you're not. And frequently, what the patient and I both realize at follow up is that the medication was making a lot less difference than whatever scheduling changes we made. I talked a little bit about clonidine and melatonin already. These aren't FDA approved for pediatric insomnia, but this is the best we have. Got to follow these families up. Otherwise, they don't get patted on the back enough for when they're doing the right thing, and the good behaviors don't get reinforced. Instead, they get better for a while, and then you see them back 6 months later when they've gotten worse again, and you miss them in the period where they were doing well. So I want to see them when they're succeeding, congratulate them on what they're doing, reinforce on their sleep diary what behaviors and what changes are making a difference, and then continue to follow them. And these are the sort of kids that even when they're stable, I'll see them every 6 months. And here's the strategies you guys have. The Autism Speaks resources are spectacular. When I first looked at this stuff last year, I was blown away by what the resources you guys have as compared to some of the other I don't know, subspecialty groups that I talk to in the sleep world, whether it be, people with MS, people with Parkinson's disease. The team approach that you guys have um, can't be appreciated in the adult world except for maybe in oncology, but no one does what you guys do. It's mind blowing to watch you guys spend as much time and effort as you do on one child. And I hope you realize it really does make a difference. So I thank you for all you guys do. Then here's some resources you can click on. If you ever have any questions, you can write down my cell phone number and shoot me a text. It's 208-695-0666. And I'm happy to answer questions, help you manage your own patients, see new referrals. We have been pretty, backed up and getting new referrals in with this transition from Salter. It's gotten a lot better over the past couple of months. I have a partner joining me in January and then another partner joining me in July. So I think we'll be able to see people in a much more timely manner. But just be aware, if you ever text me about a kid, that needs to be seen, I see them at lunch or I see them on my Monday open morning, but they get seen quickly, and it doesn't matter if they're Medicaid or Blue Cross or whatever. We're completely payer agnostic here. I don't limit my schedule by insurances, and we take everything that'll take us.
Mark, quick question. Thank you so much. What age range do you see?
Generally 2 and up. We'll see 1 and up. I generally don't do sleep studies on kids that are still in cribs just for kind of technical issues. And in general, when you get the kids, under 2, a lot of them have syndromes, and they're being followed by other subspecialists, usually in Boise in the St. Luke's world. And those patients tend to wind up at the hospital. And I think that's completely appropriate. I work with Dr. Kruskov. I worked with Dr. Yamada in the past. I think they do a great job. So I think, that's where the super young ones are best seen, but if they're 2 and up, we're happy to see them.
Wonderful. Thank you. Hey, Mark, would you mind putting your phone number, if you are okay with that,
Yep.
in the chat? The other way is anyone that wants to get a hold, if you email me, I can help connect you to Mark as well. That is very, very kind of you. Thank you.
And I'm
Wonderful
also really good with
presentation.
emails too. So if for some reason you text me in the winter and I'm away on one of my ski trips, which happens, and you don't get a reply back, I'm not ignoring you. I'm away. Just shoot me an email. And when I get back in service, I'll give you a message back. I'm putting that stuff in the chat now.
Awesome. Thank you so much. Okay, thanks for those. If we're over time, I appreciate all of you. We're going to get together again December 12th from 12:30 to 1:45 Mountain Time. The topic is understanding and managing anxiety in autistic children. Our presenters will be Elena, our panelist, joined by her colleague, Casey Knudsen, also from St. Luke's. So we hope to see you December 12th. Thank you so much. For those of you who are part of our QI cohort, hang in there. Kim is going to open the breakout room for us to join in that breakout. And for the rest of you, I hope you have a great day. Thank you. And thanks again, Mark.
You're welcome. One thing I didn't bring up is you guys changed my behavior last year. So you mailed me a gift, and I think you guys sent me this book. And I was never one to make lists and carry around a book with me. And this has become like my diary. So when Salter got broken up and my mind was in a trillion places and I was completely stressed out, I thought of Project Echo every day because this was the book of lists that kept me grounded and sane. So thank you.
We've never had that kind of testimonial. Thank you.